anatomy of the scaphoid as it relates to scaphoid fractures. We'll first discuss the two carpal rows of the wrist, the proximal carpal row and the distal carpal row. There are 8 carpal bones, 4 bones in each of the 2 rows. Within the proximal carpal row, going radial to ulnar respectively, we find the scaphoid, the lunate, the triquetrum, and pisiform. Within the distal carpal row, again radial to ulnar, we find the trapezium, the trapezoid, the capitate, and the hamate. The proximal carpal row articulates with the radius and the triangular fibrocartilage complex, or TFCC, of the distal ulna, and distal carpal row with the metacarpals. The proximal and distal rows are separated by the mid-carpal joint. Focusing on the scaphoid, it historically has been referred to as the navicular because it is said to resemble a boat, though it more likely resembles a twisted peanut. As shown here from an anterior or volar view, we can identify the tubercle of the scaphoid. The scaphoid has 5 articular surfaces, each for the radius, the lunate, the capitate, the trapezoid, and the trapezium. The video here shows an exploded view of the carpal bones to draw attention to the large articular surface area of the scaphoid. The lateral and posterior views easily depict the scaphoid articulation with the scaphoid facet of the radius and the relation with the lunate, capitate, trapezoid, and trapezium. The scaphoid has 3 main zones: the proximal pole, which articulates with the radius and the lunate, the waist with the capitate, and the distal pole articulating with the trapezoid and trapezium. As you can see, the articular cartilage, highlighted here, covers 80% of the scaphoid surface, and only the narrow area of its neck and a smaller distal portion are available for blood vessels. Looking from the dorsal or posterior view, we can see the major blood supply comes from the scaphoid branches of the artery, entering the dorsal ridge at or just distal to the waist area. It perfuses 70 to 80% of the scaphoid, including the proximal pole, in a retrograde fashion. A second group of vessels arise from the palmar and superficial palmar branches of the radial artery and enter the distal tubercle, perfusing the distal 20 to 30% of the bone, including the tuberosity. There is no blood supply coming through the proximal pole, and there is no anastomosis between the dorsal and palmar vessels. Vessels entering through the dorsal ridge specifically account for 79% of the blood supply, 14% distal to the waist, and 7% proximal to the waist. Fractures across the scaphoid, especially at the waist, may destroy blood supply to the proximal part. This disruption may cause a non-union of the fracture, and less commonly avascular necrosis of the proximal pole. There are important extrinsic and intrinsic ligaments that insert and act upon the scaphoid directly. The scapholunate interosseous ligament is known to be the main stabilizer, and the lunotriquetral interosseous ligament also plays an important role in carpal stability. We see the radioscaphocapitate ligament originating from the radius with fibers inserting into the scaphoid and onto the capitate, along with the long and short radiolunate ligaments and the ulnocarpal complex. Secondary stabilizers include the scaphotrapezio-trapezoidal ligament with other numerous carpal ligaments. Posteriorly, the dorsal intercarpal ligament provides stability, broadly extending over the carpal bones and the midcarpal joint space in a fan shape. Finally, the dorsal radiocarpal ligament attaches to the distal radius and angles across the wrist joint to the ulnar side onto the bones of the proximal carpal row. A discussion on the biomechanics of the scaphoid as it relates to scaphoid fractures. The scaphoid mechanically links the proximal and distal carpal rows. It spans both rows, as you see here, and therefore has less mobility than the other carpal bones. The scaphoid carries compressive loads from the hand across the wrist to the distal forearm. The bone flexes with wrist flexion and extends with wrist extension. It also flexes during radial deviation and extends during ulnar deviation. These factors make mobilization of scaphoid fractures difficult, especially when there's displacement. There are two main mechanisms of scaphoid injury. Compression injury usually results in non-displaced fractures originating from a longitudinal impaction force, and hyperextension bending injury results in displaced fractures originating from a tensile stress from a fall onto an outstretched hand. The scaphoid is susceptible to fractures during a fall onto an outstretched hand, or FOOSH injury. With a scaphoid fracture, the distal scaphoid tends to flex and the proximal scaphoid extends with the proximal carpal row. Now, because of this flexion distally and extension proximally during the fracture, an angulation occurs at the fracture site which gradually leads to a humpback deformity of the bone. A strong index of suspicion is the key to early diagnosis. Diagnosis should be based on history, clinical examination, and radiographic evaluation. Scaphoid fractures occur mainly in young adult men between 15 and 40 years of age and are rarely seen under 10 years old. Upon clinical examination, there is pain with any of the following, and the patient should demonstrate tenderness through dorsal palpation in the anatomic snuff box, tenderness to palpation over the scaphoid tuberosity radial to the FCR tendon and the proximal wrist crease, and/or proximal pole just distal to Lister's tubercle. Tenderness of axial compression of the thumb towards the snuff box. Tenderness as patient supinates forearm against resistance. Reduced grip strength may also be seen. For radiographic evaluation, a scaphoid view, which is an AP with ulnar deviation, and a lateral view should be obtained according to Roos. Dynamic views in 30 degrees extension are recommended as well. If radiographs are negative with a high clinical suspicion of fracture, immobilization is recommended, and repeat the x-rays in 1 to 2 weeks after the patient's initial assessment, or obtain advanced imaging such as MRI, CT. The differential diagnoses are the same as seen for radial-sided wrist pain: de Quervain's tenosynovitis, scapholunate instability, radiostyloid fracture, trapezium fracture, rupture of the FCR tendon, and ECRB or ECRL tendinitis or avulsion. Classification of scaphoid fractures is based on several different characteristics: location of fracture, direction of fracture, time since injury, and amount of fracture displacement. We will cover these one by one. For fracture location, 5 different fracture sites are proposed by the Mayo's classification: at the distal articular surface, at the distal tubercle, the distal third in 10% of cases, the middle third or waist, most common in 65% of cases, and the proximal third or proximal pole in 25% of cases. The incidence of fracture non-union increases from distal towards the middle and proximal third. The direction of the fracture, according to Roos, can be horizontal oblique, transverse, and vertical oblique. Vertical oblique fractures are very unstable as compared to horizontal fractures due to the shearing forces that come across both fragments with higher chances of displacement. Time since injury can be categorized as an acute fracture that is less than 3 weeks old, as delayed union, 4 to 6 months old, and non-union, greater than 6 months old. Lastly, the amount of fracture displacement can be non-displaced or stable, and displaced or unstable. The displaced unstable fracture is defined as the presence of a fracture gap greater than 1 millimeter on any radiographic projection as shown in type B fractures. Scapholunate angle greater than 60 degrees, normally 30 to 60 degrees. Radiolunate angle greater than 15 degrees, or an intrascaphoid angle greater than 20 degrees. Lastly, the Herbert classification defines the different types of scaphoid fractures. There are 4 types, A through D. Type A defines stable, non-displaced acute fractures. A1 is a fracture of the tubercle, and A2 is an incomplete fracture through the waist. Category B defines the unstable displaced acute fractures, B1 through B4. B1 is a distal oblique fracture. B2 is a complete fracture of the waist. B3, proximal pole fracture. And B4 is a transscaphoid perilunate fracture dislocation of carpus. Type C describes a delayed union. Type D is an established non-union fracture, with D1 showing a fibrous non-union and D2 a pseudoarthrosis. Non-operative treatment for stable non-displaced or minimally displaced scaphoid fractures is immobilization for 6 weeks with a long arm thumb spica cast, followed by 6 weeks in a short arm thumb spica cast. Operative treatment with internal fixation is indicated for unstable, displaced waist and proximal pole scaphoid fractures because they have a high risk of delayed union, non-union, or avascular necrosis. Though there's no consensus on the best treatment, prolonged cast immobilization is becoming less tolerated, moving towards percutaneous fixation, especially in younger patients who want a quicker return to work and sports. The negative prognostic factors for scaphoid fracture are late diagnosis, proximal location, displacement, angulation, obliquity of the fracture line, carpal instability, and smoking. Complications of scaphoid fractures include delayed union or non-union with or without avascular necrosis. These conditions may lead to carpal collapse and later onto degenerative arthritis. Early diagnosis and appropriate treatment of an acute scaphoid fracture are critical to avoiding debilitating wrist problems. Discussion on the general surgical considerations in scaphoid fractures. 80% of the scaphoid's surface area is articular cartilage. Here it is seen from a posterior view. The scaphoid has a distal pole, a waist, and a proximal pole. The major blood supply comes from the scaphoid branches of the radial artery, entering the dorsal ridge at or just distal to the waist area, supplying 70 to 80% of the scaphoid, including the proximal pole, in a retrograde fashion. A second group of vessels arise from the palmar and superficial palmar branches of the radial artery and enter the distal tubercle, perfusing the distal 20 to 30% of the bone, including the tuberosity. There is no blood supply coming through the proximal pole, and there is no anastomosis between the dorsal and palmar vessels. Fractures across the scaphoid, especially at the waist, may destroy blood supply to the proximal part of the bone. This disruption may cause a non-union of the fracture and less commonly avascular necrosis of the proximal pole. Operative indications are unstable fractures, proximal pole fractures, convoluted fractures, delayed treatment more than 4 weeks, displaced greater than 1 millimeter, radiolunate angle greater than 15 degrees, perilunate dislocation, and patient desire for a faster recovery. It has been shown that early fixation leads to higher union and return to work, sport, and activity. The different surgical options for scaphoid fractures are percutaneous dorsal, percutaneous volar, both standard and transtrapezial, open dorsal, open volar, and arthroscopic assisted with dorsal approach. All have similar rates of union reported. Traditionally, the percutaneous dorsal, volar, and open dorsal approaches are used. Let's take a look at these procedures in further detail. First, the percutaneous approach can be used for stable, non-displaced fractures, or fractures that may be reduced by closed methods and verified by arthroscopy or fluoroscopy. The key for screw positioning is the accurate central placement of a guide wire under fluoroscopy. The dorsal percutaneous approach requires the wire and screw be placed from proximal to distal. In the volar percutaneous approach, oppositely from distal to proximal. The percutaneous technique's advantages are that the carpal ligaments are not divided, preserving the ligament support of the wrist. The blood supply to the scaphoid is not interrupted, and there is less scarring that can limit wrist motion. Though if fracture reduction cannot be verified, convert to an open procedure. The second technique, the open dorsal approach, is used for better visualization and easier screw insertion for proximal pole fractures. The disadvantage to this approach is that there is no visualization of fractures in the distal two-thirds of the scaphoid. Fixation is from proximal to distal as opposed to the volar approach. The third technique, the open volar approach, was popularized by Roos in 1960 for fractures in the distal two-thirds of the scaphoid. The disadvantages of this approach are discomfort, scar formation, and restricted wrist extension due to scarring of the volar wrist capsule. Historically, the most simple method of fixation for scaphoid fracture was with Kirschner wires. Herbert and Fisher introduced the headless compression screw in 1984. It is a cannulated, partially threaded screw with a second thread on the screw head. Finally, the compression FT, or fully threaded screw, with a pitched thread, is a newer design that allows for firm fixation in both proximal and distal fragments of the scaphoid, with the screw completely buried below the articular surface. The advantage of this screw is that the compression is achieved by the variable pitch threads, while the fracture sees more stability with the fully threaded screw. Potential complications of surgery could be a broken K-wire or a screw, as shown by Bushnell and others, who did a retrospective review of 24 patients treated with dorsal percutaneous techniques. Other complications could be a fractured drill bit, prominent hardware, or infection. Scaphotrapeziotrapezoid or radiocarpal arthritis is still questionable as a possible complication. For a discussion on the clinical applications in the treatment of scaphoid fractures using percutaneous fixation with a compression FT screw. The dorsal percutaneous approach is best used for proximal pole and waist fractures. Let's take a look at the surgical technique for a dorsal approach. We will similarly cover the technique for a volar approach later. Place the wrist in full flexion and 20 degrees ulnar deviation to expose the proximal pole of the scaphoid. Insert a K-wire to temporarily fix both fragments and to hold the reduction in place. Place a second K-wire along the same axis to control for rotation and to maintain the reduction in case the central axis K-wire is removed after drilling. Confirm the placement of both guide wires under fluoroscopic imaging. Slide the depth device over the guide wire and make sure that it is firmly seated on the tubercle. The laser marking on the K-wire will indicate the screw length needed. Subtract 4 millimeters from the indicated length to account for the compression and the countersink of the screw. Advance the central guide wire through the far cortex to ensure that it stays in place after it has been over-drilled. Over-drill the central guide wire until it reaches the far cortex. Using the appropriate driver, insert and advance the screw until it is completely seated and compression occurs. Confirm placement and length of the screw on imaging, ensuring that both the leading and trailing edges of the screw are not protruding out of the scaphoid. If you are satisfied with the stability of the scaphoid, remove both guide wires. For the next technique, the volar percutaneous approach, the screw starts at the scaphoid tuberosity in a retrograde fashion and is best applied for distal pole fractures. Open volar and transtrapezial approaches are less common for retrograde screws. Advance the wire past the fracture site to the far cortex. Check under fluoroscopy. Place a second K-wire parallel to the previous to control for rotation and to maintain the reduction. Confirm the placement of both guide wires under fluoroscopic imaging. Measure the screw length needed with the depth device placed over the guide wire. Subtract 4 millimeters from the indicated length to account for compression and countersink of the screw. Advance the central guide wire through the far cortex to ensure that it stays in place after it's been overdrilled. Overdrill the central guide wire until it reaches the far cortex. Insert and advance the screw until it's completely seated and compression occurs. Here we have the final fixation.